Okay, we are live now.
Okay.
Dr. Subhajit Banerjee, our president, please start the program.
Okay. So, am I audible now? Okay.
Yes, you are on.
Yeah. Good evening, everybody. On behalf of AY West Bengal, I welcome you all in today's webinar on management of mucormycosis in the context of COVID pandemic. And you'll be pleased to know that there are two learned and respected speakers, Dr. Wendy Smith and Dr. Luigi Martini from United Kingdom. And the moderator is Professor Dr. Dwaipayan Mukherjee of Kolkata, our ex-secretary and trust board member. You are well aware that due to this COVID pandemic, we are holding all our academic activities in virtual platform. We are conducting orations, monthly clinical meetings, journal clubs, postgraduate orientation programs, digital postgraduate conferences, webinars regularly, and all our members have taken a keen interest in attending the same. We will also be pleased to hear that BJones, our journal, is an open access, peer-reviewed journal and DOA certified and indexed in Copernicus. I shall not take any more time and request our Honorary Secretary, Dr. Snehasis Barnan, to say a few words. Over to Dr. Snehasis Barnan, please. Thank you.
Good evening to all who have joined us tonight on AY West Bengal YouTube channel. I request you all to subscribe to our channel to see all the academic programs of AY West Bengal. Just a minute. Our president, Dr. Subhajit Banerjee, has mentioned about the academic activities of AY West Bengal. Besides these academic activities, our association, like a big family, extended support to our members during our fight against COVID pandemic. We have distributed masks and kits for safe practice to all frontline warriors, including junior ENT surgeons working at hospitals throughout West Bengal at the beginning of the pandemic. We have extended all possible support to our members who have suffered severely from corona infection. Mucormycosis has emerged as an epidemic during this corona pandemic, and ENT surgeons are again in the front line in the war against this epidemic. Every day, we eagerly wait for new discoveries, new theories, and new treatment ideas to build up our armamentarium. Tonight, we have Dr. Wendy Smith and Professor Luigi Martini as our guest speaker. I want to share the profile. Okay. So, Dr. Wendy Smith is otologist at ENT department, Kettering General Hospital, UK. Her special interests are surgery for cholesteatoma, including CATs and mastoid obliteration, endoscopic ear surgery, as well as managing patients with dizziness. She has published widely, including 3 chapters on drug therapy in Scott Brown's otolaryngology and head neck surgery, and has presented at national and international meetings. She is a keen educator with roles as an honorary senior lecturer at Leicester Medical School, co-chair for the Intercollegiate Royal College of Surgeons, ORL-HNS, MRCS ENT examination. Faculty of the East Anglian Temporal Bone course and was until recently a foundation program director. She is the Education Secretary for the British Society of Otology, Honorary Secretary for the Midlands Institute of Otolaryngology, and member of Council for the Otology section of the Royal Society of Medicine. Welcome, Dr. Wendy Smith. Professor Luigi Gino Martini. Professor Martini is registered practicing industrial pharmacist and a fellow of the Royal Pharmaceutical Society. He is a visiting professor in pharmaceutical innovation at the King's College. Professor Martini is also visiting professor at the University of Bradford. He is past chair of the Industrial Pharmacists Group of the Royal Pharmaceutical Society, past president of the European Industrial Pharmacists Group, and in 2016, Professor Martini was appointed a fellow of the European Industrial Pharmacists Group. We welcome Professor Martini. I am sure today our guest speakers will enlighten us with some new aspects in the management of mucormycosis. So without wasting any time, I hand over the platform to Dr. Dwaipayan Mukherjee, Professor, KPC Medical College, Kolkata, Organizing Secretary of AYCon 2017 and ISOCon 2019, Treasurer and Trustee Board Member of AY West Bengal, Editor of 10th and 11th edition of SK De's Fundamentals of ENT and Head Neck Surgeries, and author of many articles. I request you to set the context and moderate the webinar. Over to Dr. Dwaipayan Mukherjee. And also, I request all the audiences to share your comments and post your questions in the chat box for discussion. And also, I request Dr. Dwaipayan Mukherjee to introduce Dr. Amitava Raychaudhuri also. We have with us Dr. Amitava Raychaudhuri.
Thank you, Dr. Snehasis Barman. So, our President, Dr. Subhajit Banerjee, and Dr. Snehasis Barman, Honorary Secretary of AY West Bengal, already have introduced Dr. Wendy Smith and Professor Dr. Luigi Martini. Today, we will also have with us Professor Dr. Amitava Raychaudhuri, Professor in RKMSP and Senior ENT Consultant. At the end of the session, we will discuss and we will actually exchange views and ideas related with the treatment of COVID and mucormycosis. So that there is exchange of views among ourselves, and that will be beneficial for all. So without wasting any time, my role is to set the context of this meeting. As we all know, at the time of second wave of COVID, we have faced a sudden surge of mucormycosis in India. Now, mucormycosis is a fungal infection caused by a ubiquitous mold, Mucormycetes, found in the environment, in soil, and in decaying organic matter. It is one of the important opportunistic mycosis in severely immunocompromised patients. Now, whether mucormycosis is different in India? Yes. Compared to the Western world, India data showed 170 times higher incidence of mucor here. And uncontrolled diabetes is the major risk factor and overshadows all other risk factors. Rhino-cerebral mucormycosis is the most common clinical type in India rather than the pulmonary and other types. Spectrum of mucorales causing infection is wide. These are the important predisposing factors for the mucor infection. The most important predisposing factor is hyperglycemia, and undiagnosed or uncontrolled diabetes are always considered as one of the main risk factors for the mucor infections, along with ketoacidosis, corticosteroids, and anti-interleukin-6 directed strategies in COVID patients, cancer, and post-transplant patients, and neutropenia on chemotherapy. Now, at the time of second wave of COVID, we were actually facing three-pronged assault simultaneously. Sudden surge of number of patients, moderate and severe cases of COVID-19, causing immune dysregulation, ciliary dysfunction, and thromboinflammation. India is the diabetes capital of the world, so already we were having large number of diabetic patients. And for the moderate and severe cases of COVID, we had to give the corticosteroids that ultimately leads to impairment in the neutrophil migration, ingestion, phagoliposomal fusion, and also it exacerbates the hyperglycemia. Now, for COVID-associated mucormycosis, multiple factors were acting simultaneously. Steroid causes impairment of the neutrophil migration, ingestion, and phagoliposomal fusion. Hyperglycemia causes inflammatory state, and antiviral immunity to COVID-19 paradoxically potentiate this inflammatory condition. COVID infection per se are also helping the growth of the mucor, as because there is alteration of the iron metabolism in severe COVID-19 infections due to interleukin-6 stimulate ferritin synthesis and downregulates iron export, causing hyperferritinemic state, and there is excess intracellular iron, resulting in tissue damage and free iron in the circulation. This excessive free iron in the circulation is also very helpful for the growth of the mucor. Another hallmark of the COVID infection is endothelialitis. Autopsies indicated widespread severe vascular endothelial injury in COVID-19 than patients died of influenza A and H1N1. And endothelial adhesion and penetration are also critical early step for mucormycosis. Now, acidemic state and hyperglycemia induce the endothelial receptor glucose regulated protein GRP78 plus mucorales receptor protein homologs called H, combining these two causing perfect storm for increased adhesion and penetration of mucorales. So there is cascade of events: dysregulated innate immune response, ciliary dysfunction, cytokine storm, thromboinflammation, microvascular coagulation, eventually immune exhaustion, and favorable environment for mucor growth. Now, there are 5 types of presentation of mucor infections, but we are interested here with Rhino-orbito-cerebral infection because that is the commonest one presently in India. Now, why we are so concerned about this disease? Because this is angioinvasive, tissue destructive, no boundaries are there, vital structures are vulnerable, rapid progression, late diagnosis, mortality rate was so high, maybe up to 50 to 56%, and medical treatment is toxic and also very costly. Unfortunately, many of the patients presented with late symptoms like loss of vision, palate invasion, and disseminated diseases. Now, at the time of diagnosis of the Rhino-orbito-cerebral disease, 2 things are most important. One is MRI with contrast of the PNS and brain, and another is endoscopic collection of debrided tissue or biopsy for fungal stain or microscopic examination or for culture. In fungal stain, we may have non-septate or posiseptate Livon-like hyphae or aseptic filamentous hyphae for the mucorales. And biopsy remains the mainstay of diagnosis, and the benefits of the procedure usually outweigh the risk. That means if we are facing any critically ill patient not actually stable for the general anesthesia, in those cases also, we can go for diagnostic nasal endoscopy for collection of the specimen under local anesthesia. Why MRI with contrast? MRI with contrast is always helpful in this disease over CT scan, because by doing MRI with contrast, we can actually assess the extent of the disease, and it will be highly helpful for the surgeon at the time of actual debridement or at the time of endoscopic operations. And sometimes it is helpful to actually assess the overestimated or underestimated disease. These are the hyphae in lactophenol blue stain and KOA stain. And nasal endoscopy at the earliest possible time is always helpful. So we can actually take this type of swab from deeper inside the nose, but for confirmation of the diagnosis, it is always better to have one tissue like this from the devitalized area, and we can actually diagnose the disease more precisely when we are taking biopsies like this from the deeper part of the nose for better accuracy. Now, for the treatment of the COVID-associated mucormycosis, a team approach is required with multiple specialties. 3 major modes: controlling the underlying disease, surgical debridement of the infected tissue, and specific antifungal therapy. ENT and surgical team should be consulted for debridement, and delay should be avoided. Surgery found to be an independent variable for favorable outcome in mucor patients. Removal of the devitalized tissues until to reach a plane that bleeds, and antifungals will reach the vascularized areas. So all the hyperintense area can be left behind, because that can be taken over by the antifungal drugs. Liposomal amphotericin B is the choice of first-line therapy for 3 to 6 weeks. Right now, we are following here this protocol. Prevention is always better than the cure, or we are treating the disease simultaneously. We are following these preventive protocols so that we can actually restrict the number of newer cases of mucor infections. Environmental cleanliness, to have no exposure to decaying organic matters like breads, fruits, vegetables, soil, compost, excreta, etc. Mask is helpful to reduce exposure. Good control of hyperglycemia, glucose monitoring in COVID-19 patients requiring steroid therapy, optimal steroid uses in moderate and severe cases, that means right timing of the initiation, right dose, and right duration, optimal and selective use of antibiotics and antifungals. And we should not consider all the cases with blocked nose as cases of bacterial sinusitis, particularly in the post-COVID-19 period. During discharge of the patients, we are giving advices about the early symptoms or signs of mucormycosis to the relatives of the patients, and simple tests like pupillary reaction, ocular motility, sinus tenderness, and palatal examination are now a part of routine physical evaluation of COVID-19 patient at the time of post-COVID follow-up. Fortunately, by following all these preventive measures, we are actually experiencing less number of cases of mucor infections in last fortnight. So in the summary, COVID-associated mucormycosis should be suspected in diabetic patients with severe COVID-19 infection. Steroids should not be given indiscriminately. Good glycemic control while managing COVID-19 is essential. We should be very cautious when we are dealing with older age, diabetic, ICU admission, and glucocorticoid therapy for the COVID patients. Cost of treatment is a serious challenge in India, and considerable number of patients cannot afford the therapy. But fortunately, for last few weeks, central government and most of the state governments in India are providing antifungal therapy free of cost to the common people. Thank you for patience hearing. So without wasting any time, I will hand over the session to Dr. Wendy Smith and Professor Luigi Martini for their deliberation. Most likely, they will highlight some newer therapy related with the treatment of COVID and the mucor infections. Over to Dr. Wendy Smith and Professor Luigi Martini.
Okay, so hopefully you can see the slides. So thank you all very much, the AOI of West Bengal, for allowing us to come and speak to you today via this webinar, and for your kind introductions. So following on from the excellent talk that we've just heard, and the one by Dr. Chakrabarty that we had last Saturday, when he presented the experience of 6 cases of mucormycosis in a tertiary medical institute, we would like to discuss the management of mucormycosis in the context of the COVID-19 pandemic. For some reason the slide doesn't want to go. Okay. So firstly, we'd like to declare that these are our own personal views. I have no conflict of interest to declare, but Professor Martini has advised a stabilised hypochlorous acid provider, but this is not promotional today. So in this presentation, I'm actually going to go over quite a lot of what's already been said earlier that we just heard, but I will go through it again anyway, and there might be a few additional bits of information. So we're going to go through what black fungus is, why it's become prevalent, the current management, about hypochlorous acid and what we mean by when it's stabilised, as well as the future role of stabilised hypochlorous in the management of both COVID-19 and the black fungus. So black fungus is a serious, but before was fortunately quite a rare condition, and it's caused by a group of molds called the Mucormycosis. And as you can see, there's a number of species. And as it's been said before, the fungi are ubiquitous in the environment, and they like soil and decaying organic matter such as leaves, compost piles and rotten wood. And it's known as black fungus not because it's black itself, but because the fungus results in blackened tissues due to necrosis. And as already said, there's 5 types of mucormycosis, which are classified according to the organs affected. There's the Rhino-cerebral, affecting the nose and the brain, pulmonary, gastrointestinal, cutaneous, and disseminated. And it, as said, the lung and sinus forms of infection occur when someone with an underlying health problem, such as diabetes or are immunosuppressed, breathe in these spores. But the normal process of phagocytosis of the spores by the macrophages fails to occur. You then get germination and hyphae formation, resulting in an infection. And it's these fungal hyphae that actually invade directly into the blood vessels, producing tissue infarction and massive necrosis with bone destruction. So this condition is rare in USA and Australia, reporting rates of about 1.7 and 0.6 per million population per year, respectively. However, even prior to COVID-19, mucormycosis was about 70 times higher in India and Pakistan, with about 140 cases per million annually. So it was on the 25th of May this year that the Indian government declared that the black fungus was an epidemic. And by the 5th of July, more than 40,000 cases have occurred in patients mostly recovering from COVID-19. So Deepak Garg earlier this year reported the association of mucormycosis and COVID-19, and he described 8 cases. 3 were in USA, 2 from India, and 1 case each from Brazil, Italy, and the UK. Subsequently, other countries have also appeared to be affected, including Pakistan, Nepal, and Bangladesh. And the association also appears to be present in Russia, Middle East, and South America. So obviously, public awareness has now been extended across India because of the prevalence, and that's been by media, by internet, explaining to the public what it is, and hopefully to show what the signs are, and then what can be done about it. So this slide lists the clinical presentation of mucormycosis. So once the fungus invades the nasal sinus mucosa, it can spread directly to the orbital apex and then to the brain. Early diagnosis is difficult since the patients often present with really non-specific symptoms. One of the key features is that the symptoms are usually unilateral. Because the condition can lead to angioinvasion and tissue infarction, infection of, say, the ethmoid sinus may penetrate through the bone and soft tissue, causes an eschar to form over the infected area, as shown in the patient in the lower photo. A black necrotic eschar can occur on nasal turbinates or the hard palate, as I'll show in the next slide, and this is characteristic of a maxillary sinus involvement. As the infection progresses, you get a lot of later symptoms such as facial or periorbital swelling or numbness. And they are actually quite a lot of the characteristics that we would normally see in a bacterial orbital cellulitis, where you'll see patients having developed blurred vision, chemosis, proptosis, ophthalmoplegia, corneal anesthesia, and loss of vision. And this really indicates that there's been invasion of the optical nerves and vessels. You can then get mental state changes, hemiparesis, and seizures, and that would indicate that there's been some intracranial invasion. And what's quite scary is that the time from onset of initial symptoms to late symptoms and the signs that are really quite characteristic of the disease may be as short as 1 day. So really the development of the late symptoms and signs indicates a poor prognosis. And really, by the time you go and get signs in the orbital apex, it's often too late to save the patient's vision, their eye, or even their life. And it is typically a rapidly progressive infection, and the disease is associated with a high mortality rate. So here's some photographs. The one on the top left shows the sort of blue blackish appearance that you see on the middle turbinate. That's probably maybe a bit more localized. Then you've got it where the maxillary sinus has been affected, where you see the blackening of the hard palate on one side. The patient on the top right, she's got the eschar, which is quite characteristic of ethmoid involvement. And you can also see that there's periorbital swelling, and then a very severe case in the lower right. So obviously, in addition to history and clinical examination, investigations are useful. Full blood count's useful. Sometimes you get a neutropenia. The CRP and ESR are often raised. It's important to check the renal profile as well, particularly when you're thinking that you're going to have to start them on amphotericin B, which we know is nephrotoxic. Arterial blood gases should be done, and that helps us determine the degree of acidosis. And then, as already mentioned, glucose and HbA1c to determine the presence and control of diabetes. And this is all useful investigations. It's important to realise that there's no routine serological test for mucormycosis. And the blood test that we tend to use for fungi, such as beta-D-glucan or aspergillus, galactomannan, do not detect the mucormycetes. Nasal fluid and sputum can be collected and examined under the microscope. And this slide here demonstrates the typical ribbon-like hyphae, which branch at about 90 degrees. Fungal culture can also be useful. And as already mentioned, biopsies should be taken, and you need to look under the microscope at the hyphae and spores. And it's important to confirm from the fungal species, what it is, because some of these patients do develop COVID-19 associated pulmonary aspergillosis, known as kappa. So just to recap, imaging using CT and MRI is particularly useful, especially when you're considering surgical debridements. CT scans are useful since they do show the anatomy, just like we do when we're doing FES surgery. And they show some bony involvement, but it's actually the MRI scan which really is able to show where there's been necrosis and spread beyond the paranasal sinuses, and therefore very helpful when we're trying to plan the surgical approach. So the image here on the left shows an axial image of the CT scan, and it's really quite non-specific. It could be almost a bacterial orbital cellulitis where you've got opacity in the anterior and posterior ethmoids. You've got obvious proptosis there of the right orbit, and you can actually see a bit of fat stranding here. So that also indicates that there's already been spread outside the sinuses. When you come to the MRI scan with contrast, you can see here on the left side, you have got the contrast there in the mucosal lining. Whereas on the right side that's been affected, because it's now avascular, you don't get the contrast there being shown up. And the lesion itself, or mucormycosis, is an intermediate to low intensity on both T1, T2, and of course, even when you've got your contrast with T1. The other advantage of the MRI scan is that it's great for looking for the complications. So you can pick up things like leptomeningeal enhancement, intracranial granulomas, cavernous sinus thrombosis, carotid pseudoaneurysms, and cerebritis. So the treatment can be divided into medical and surgical. And the medical one is first aimed at correcting the underlying medical problems, such as diabetic ketoacidosis, and using a combination of the antifungal drugs. Primarily, it's high-dose amphotericin B, which should be initiated as soon as the diagnosis is suspected. So lipid-based amphotericin B, it destroys the cell wall of the fungus and has been the first-line medical treatment of mucormycosis. You do get the liposomal formulations, which are able to deliver high doses whilst protecting the renal function to some extent. And then posaconazole, which is triazole that inhibits growth of the fungus, has been proposed as a promising adjunctive or alternative treatment for mucormycosis. Now, it's important to remember that other medicines that are used for fungal infections, such as fluconazole and voriconazole, do not actually act against the fungi that cause mucormycosis, so you can't use those. You need to monitor the patients when they're on amphotericin B, probably even alternate days. You want to know about serum creatinine for electrolytes and to monitor the renal function, and also to detect hyperkalemia. Now, these patients are often quite septic. You need to make sure that they are kept well hydrated, and sometimes they need to go and have extra potassium supplements when they're having the amphotericin B administered. Because the systemic medications are often unable to actually reach the infected tissue due to the vasoocclusion, surgery should also be considered early in the course of treatment. And basically all the necrotic tissue needs to be surgically removed. This may require extensive surgery involving removal of the palate, the nasal cavity, the eye, and even parts of the brain. And Hosini et al. Describes that after the fungus proliferates in the nasal cavity, it goes to the sphenopalatine foramen, into the pterygopalatine fossa, can go through the inferior orbital fissure and eventually into the retroglobal space of the orbit, resulting in the ocular signs. And then it can also go from the pterygopalatine fossa into the infratemporal fossa. It can also spread to the facial soft tissues, the palate as well. So the pterygopalatine fossa probably is affected in nearly all cases. And as discussed last week on the webinar, really surgical exploration and debridement should be considered at the primary surgery. And sometimes more than one operation is required. So going on to other considerations after surgery, people have advocated douching with even amphotericin. We would also maybe suggest the use of hypochlorous acid, and we'll come on to that a bit later on in this presentation. The disease must be monitored carefully for signs of recurrence. So CRP is very useful. So if you see that climbing up again, you might think that there's some more active fungal infection present. Endoscopic examination, and even consider repeat CT scanning. So as mentioned before the advent of amphotericin B, mortality rates were huge, with mucormycosis being as high as 90%. And the disease still, unfortunately, continues to have high mortality rates. One study reported a range of between 50 and 80%. Another study reviewed 929 cases, and they found that they had a 61% survival rate treating them with just amphotericin B, 57% if you just use surgery, but they could manage to get 70% survival in those treated with both surgery and amphotericin B. So if we're able to make an early diagnosis, that means that we'll be able to get away with less invasive surgery and better quality of life for the patients as well. So here's a couple of endoscopic pictures, and what you might sort of appreciate is that this is from the middle turbinate, and it's got a sort of slightly purplish blue hue to it. This is the nasal septum, which is already quite blanched, and that's not just to vasoconstriction, this is actually vasoocclusion. And then just beneath the uncinate, you can actually see some pus here associated with it. And what's interesting is if you go and put your sucker onto this area here where it is avascular, you don't get much bleeding. Whereas if you touch the inferior turbinate, say, which hasn't been affected, or you go to the other side, then you will get bleeding. In this same patient, you can see that there's a huge area here of some necrotic tissue, and all that should be biopsied and sent off to the lab. And you want to really get back to healthy bleeding tissue. It's interesting as well, because sometimes, because it's insensate, you don't even need a general anaesthetic for these procedures. And because they don't bleed that much, you can do it as well without the patient having too much problems with bleeding. Unfortunately, if patients are presenting late or it's really rapid and onset, you get much more in the way of bony erosion, and you have to debride until it's healthy bone. And here you've got an example where there's been orbital exenteration. Beds can still be useful in these cases because certainly as an otologist, I get a much better view when I do use the endoscope. So just to really recap on why black fungus has become so prevalent in India, we can separate this into patient factors and environmental factors. So one explanation is because of the number of COVID-19 infections, and India unfortunately has experienced very high rates of COVID. The COVID-19 virus, as we've seen, can damage the lungs and blood vessels, and this is probably makes it more susceptible to having fungal infection. India also has high rates of diabetes, and when diabetes is poorly controlled, and as mentioned, a lot of people don't know that they have got diabetes. When the blood sugar is high, the tissues become relatively acidic, which again is a fantastic environment for the Mucorales fungi to grow. All of the mucormycosis cases published in scientific journals globally between 2000 and 2017, diabetes was found in 40% of the cases. However, it's interesting that 94% of the patients with COVID-19 associated mucormycosis had diabetes, and it was poorly controlled in 67% of these cases. We know the sinus form is more common in patients who are immunocompromised or who have diabetes. And as mentioned, patients with diabetes tend to have more severe COVID-19 symptoms and probably required more severe corticosteroids, which themselves increase the risk for developing mucormycosis. Some of these patients have self-medicated with steroids, and this was probably exacerbated when there were issues with oxygen availability. There was a time when lots of broad-spectrum antibiotics were widely used, and this may also contribute to the development of fungal infection, as does malnutrition and the extremes of age. It's interesting that neutropenia is associated with risk factors for mucormycosis. However, COVID-19 actually produces a neutrophilia or a lymphopenia. So we come on to the environmental factors, and there's probably a high environmental burden of mucormycosis in India, as suggested by the pre-COVID-19 levels of black fungus being so much higher here than in other parts of the world. There have also been previous healthcare associated mucormycosis outbreaks. You may remember there was the wooden tongue depressors, causing hospital linens and the use of non-sterile medical devices. About 60% of the patients admitted to hospital for the treatment of this black fungal disease neither took steroids or were on oxygen support during the COVID-19 treatment. However, these patients underwent a lot of RT-PCR tests multiple times to see whether or not they were COVID positive or not. So the question is, could this pandemic be due to swabs? In Western countries like UK and USA, these swabs are sterilised using gamma radiation. However, in India, there's no quality control on their production and handling, and that's why even when steroids and oxygens were extensively used in Western countries like the UK and USA, patients didn't really seem to contract the fungal infection, maybe because the swabs were sterilised. Since nearly all the cases are the Rhino-orbito-cerebral mucormycosis rather than pulmonary, it sort of works against it being a problem with contaminated oxygen cylinders as a cause of this outbreak. The oxygen supplied to hospitals for medical purposes actually is 99.5% pure, and the high pressure and extremely low temperatures, which is below 183 degrees, at which it's stored and transported, really it's impossible for the fungus to survive. However, there was an exponential surge in the number of coronavirus infections this year, and this led to the demand for medical oxygen to be far beyond the supply capabilities. Because of this, many people had to go and use industrial oxygen or oxygen concentrators. Secondly, it became apparent that instead of using distilled water, people have been using tap water in the flow meters for the oxygen cylinders and the oxygen concentrators. And therefore, the fungus manages to reach inside the body, maybe through contaminated water or mold, tainted humidifiers, oxygen pipes, or face masks. So at that point, I'd like to hand over now to Professor Martini to talk about hypochlorous acid. Thank you.
Thank you, Wendy, and good evening, everybody. So hypochlorous acid, what is it? It's not new. It's been around for many, many years. In fact, it was first discovered by Sir Humphrey Davy in the 1800s. It's also known as HOCl. What people don't really appreciate about hypochlorous acid is it is actually a naturally occurring substance. Your white blood cells, your T cells, actually do produce hypochlorous in vivo. And it's this particular substance that kills cancer cells, for example, or other antigens when your immune response is evoked. So it's actually a naturally occurring substance. However, of course, how you make it is also very important. And we'll touch upon that in this presentation because that's the key. How it's made artificially, so to speak, is something that we feel you should be aware of. It's very potent. It kills bacteria very quickly, spores, it's a fungicide, and also kills a wide variety of viruses, including the coronavirus, extremely quickly, less than 30 seconds. What people don't really appreciate is that it doesn't contain any solvents. There's no alcohol, there's no solvents, there's no irritancy, and actually no risk of fire risk because it's effectively an aqueous substance. So it's not like an alcoholic gel which can burn. So particularly important in very hot climates, this material will not combust. Therefore, we know, and it's shown, it's ideal for mucosal membranes. You can spray hypochlorous, stabilized hypochlorous. I want to emphasize what I mean by that in a second, onto mucosal membranes, into your eyes, your nasal passages, in the open wounds, the broken skin. It is non-irritant. Again, very, very important point to note. Wendy, next slide, please. So hypochlorous has been used for many, many years. Like I said, discovered in the 1800s. It was used in the 1900s during the First World War, battlefields, military hospitals. And so it's had a wide variety of uses, effectively as a sanitizer, hand sanitizer, surface spray. Question mark, can it use befogging and misting? And I use the word question mark because there's a little bit of debate about whether it can be used as a mister. And I believe that the confusion first came about during the Ebola crisis about 5, 6, 7 years ago, where a number of chlorinated systems were being used to disinfect people. Actually, they were spraying people with these systems. And there were cases of things breaking down and people getting exposed to highly concentrated chlorinated products, which you all know are irritants. If the hypochlorous is stabilized, again, I'll talk about that in a second, what I mean by that, we do believe it could be used as a mister and fogging agent. So there's some debate. Hypochlorous has been around again many years, like I said. The FDA use it, allow it to be used for washing food. In many dental systems in dentistry in America, they will use it for as mouth rinse, and some dental surgeries actually do use it to fog as well. So the question mark about fogging, I believe, has been confused with what happened in Ebola and what's happened in recent months when non-stable forms of hypochlorous have been used. So like I said, has been used as a mouthwash, thank you, Wendy, with the slide, with no adverse effects, has been used in people's eyes, and actually used actively for wound healing. What you see an example here is, and by the way, this data has been generated by independent researchers. As you can see, the hypochlorous is very effective at removing biofilms, particularly in open wounds, which allows you then the wound to heal far more effectively, and also prevented bacteria reforming. Also stops odor as well, and that's something that's very noticeable when hypochlorous is being used. Next slide, please, Wendy. And it has been used a lot in South Korea. It was used to disinfect food, people, hospital wards, mass transit. And if you look at the data, they don't seem to have a bigger problem with COVID than, say, other countries. Now, that's speculation, you may say, and probably, it is speculation, but it is worth noting that when countries are using it, they do have lower instances of transmission. Next slide, please. And this is very, very interesting. So Japan was using hypochlorous to disinfect pubs, their transit systems. And the problem was they were using unstable forms of hypochlorous. So what happens, the hypochlorous will break down. It forms very highly concentrated chlorinated solutions, almost like a bleach, and you can get irritation. And it's really interesting that when they stopped the use of hypochlorous, and they were using it in schools, playgrounds, offices, in June 2020, and you can see after a period of time a large increase in cases of COVID-19. Well, there could be a number of reasons for that. Obviously, the lockdown rules might have been relaxed, different variants, going on. However, it's just an observational point that when they stopped using it, you saw an increase in numbers. Let's put this in perspective. Japan has 125 million people in an effectively small island, very high population density, say compared to, say, even the UK. And the incidence of COVID was actually very, very low compared to other countries. So just a really interesting observation that was being made. Next slide.
Okay, so
hand over to you.
Okay, so part of the work that we were looking at as well, looking at the paper to see where we could actually use hypochlorous acid, was a review seeing that since we know that high loads of COVID-19 virus is associated with higher mortality rates, there's been an interest in using maybe hypochlorous to potentially reduce the viral load in the upper respiratory tract. So certainly in the UK, it was advised by ENT UK that we got our patients to gargle with dilute betadine solution before we even dared look in their mouths, so that it would try and reduce the viral load and reduce the risk to healthcare people when we were going to be examining their throats. So this patient by Garitani et al. Showed in their in vitro study that hypochlorous acid efficiently and safely inactivated the COVID-19 virus. And they also carried out intranasal and oral irritation tests using standard methods and found it to be non-irritant. In 2008, so some time ago, in laryngoscope, Kim et al., they published another in vitro study, and they used 3.5 parts per million hypochlorous acid, and again found no toxicity to human nasal epithelial cells, but it was actually more than 90% active against fungus, including rhizopus, which you know is one of the mucormycosis fungi. So the previous two papers were in vitro. So the question is, does this translate to in vivo? So this paper, it was a prospective, randomized, placebo-controlled study, recruiting patients who had chronic rhinosinusitis. So they recruited 50 patients, and in the end, 19 patients completed the study arm using hypochlorous acid, and 20 the placebo arm, in which they got patients to use saline. They ensured that the SNOT-22 scores were the same in both groups, and after 1 week, there was an improvement in their SNOT-22 scores in both arms. However, what's interesting is that at 2 and 4 weeks, those in the hypochlorous arm had significantly lower SNOT-22 scores. You et al. Found that hypochlorous acid was not only safe with no adverse effects reported, but it was actually better than saline in the management of chronic rhinosinusitis. Over to you now, Gino.
Okay, thank you, Wendy. So why has the uptake of using hypochlorous been slow? And I think, this is, I think, the crux of the issue. So like I said, hypochlorous is not new. It's been around for many, many years. It certainly was used in the 1900s. And the issue is, traditionally, it was made in many hospitals by a process called electrolysis, where effectively you're using electrochemistry to actually make the hypochlorous. The issue with this is that you have very, very short shelf life. Once exposed to the solutions of hypochlorous, last a few days, maybe a few weeks. The problem then also becomes, once air has been exposed to the product, it's actually often the case that hypochlorous produced by electrolysis upon exposure to air will have inconsistency and unstable pH levels. So they can become very alkaline and also very high levels of chlorine. But basically what can happen is they can end up forming a mild form of bleach. And we all know bleach can irritate the skin and irritate the eyes. So that's been the major problem. How it's been made traditionally has been short shelf life, and it starts to degrade, and it becomes in some form, effectively a chlorinated product. And that's what's been causing the issues. Now, we suspect has been causing some of the issues in the past when it has been trying to be used en masse. If you don't make it stable, then you will have a problem. Next slide, please. So what I can say is that the chemistry's moved on, and there are what we call stabilized hypochlorous acid, where new production methodologies have been used. And these new formulations now have much, much longer shelf lives, up to 18 months, right? And also when they are open to the environment, they're a lot more stable, a lot more consistent, and the pHs are by between 5.5 to 6.5, very much akin to your skin pH and physiological pH. So this, what we believe now, is something we felt duty-bound to raise your attention, because clearly there has been some issues in the past, but what's happened in the past shouldn't be dictating what's going on in the future because of the advances in technology. So in short, a new process has been developed to make these hypochlorous solutions stable, gentler in terms of pH, and once open can be used for longer periods of time than traditional forms of hypochlorous. Next slide, Wendy. So we are aware of stabilized hypochlorous now being approved in the UK, and this product is now also being approved across Europe. Just been approved in Germany, and it'll be rolled out to the rest of the EU. This has only been happening in the last 3-4 months. Last 4 months. So it really is a new system that's been introduced. Next slide, please. So what are the roles for stable hypochlorous? Clearly, sanitize hands, faces, surfaces. Fogging, we believe can be used, but it has to be used at the moment in what we call empty rooms where people are not present. But I think if more work was to be done in that area, I think it would show that it's actually safer to do. But certainly, you wouldn't have to worry about fogging a room and then quarantining the room for a couple of days. You could probably walk into that room straight away after the fogging had been done. But what we're saying right now is fogging an empty room, and then once the fogging has been done, then there's immediate access. Whereas for hydrogen peroxide deep cleanse, you have to quarantine the room for a day or two. Future treatments, again, obviously the independent research that's been shown has shown there's a place for it in nasal douching, eye irrigation, and clearly it has fungicidal properties, virucidal properties, antibacterial properties. So it shows itself to be a very versatile, low cost, no alcoholic, no solvent system that could probably help wound healing as well. Next slide. So again, we'd probably say it could be used in areas where masks are being used to cleanse masks, hand washing. There's a study ongoing now, particularly in high intensity medical rooms, aseptic suites, where people with eczema are going to aseptic suites. The hands are very sensitive to the alcohol and they've got eczema. And we're doing a trial now in a hospital in the UK where they're going to try and use hypochlorous as a way of being able to avoid the alcohol gel damaging the skin. And that trial's ongoing. And I think clearly education about diabetes and of course avoiding exposure, wearing a mask, particularly in the fortnight after having COVID-19. Do you want to finish off here, Wendy?
Okay, so basically in summary, we've discussed about what black fungus is and how it can be managed at the moment, and what hypochlorous acid is, and what the other measures that can be taken to try to prevent black fungus infections. So we're now able to open the floor. If you've got any questions, there are email addresses and you can contact us as well as after this presentation. Thank you.
Yeah, so like as Wendy said, if there are questions you'd like to ask, you're more than welcome to email us. If we can answer all your questions today, we'll then take those questions away and give you answers in reply. So, thank you.
Okay, thank you, Dr. Wendy Smith and Professor Luigi Martini for your excellent lectures. Now we are having with us Professor Dr. Amita Raichaudhuri, and we are having a couple of questions. So I will like to ask this question to all of you. The first question is, if a patient presented with COVID-19 and mucormycosis together, what are your suggestions for surgery? Should surgery be performed as early as possible, or should we wait for the patient to become negative? Dr. Wendy?
I think that knowing that it's very rapid in onset, I mean, it seems to happen more in the sort of 2 weeks after people are recovered from COVID rather than the acute phase. And as we know, some of the tests, you're picking up the protein and not necessarily the live virus if you're swabbing people. So, and their symptoms probably have been going on for quite a while. But if you go and wait, these people will die from the fungal infections. So it's the case of protecting the staff as much as possible. And I think that, you know, there's an argument to make sure you've got lots of stable hypochlorous around, which will, you know, sort of kill the fungus and the COVID-19 as well.
Dr. Raichaudhuri, what is your opinion?
Thank you, Dwaipayan. I think this COVID-19 associated mucormycosis is a surgical emergency. We all think it that way, like Dr. Smith said, that irrespective of whether the patient is COVID positive or negative, it is likely that many of these patients would have become negative by the time they have presented to us. But once we detect them, irrespective of that, it's a life-saving surgery. So we have to do the surgery. If we do not embark on surgery, we cannot reduce the fungal load, and therefore the medical treatment will not work so much well. And as far as the hypochlorous acid is concerned, I think what Dr. Smith just now said, we have definite evidence from the literature, what they have said, that it's very good and well established for environmental sanitization purpose, but for nasal use, we need to have more studies in our country, or especially we can take this advantage in our country where there is an epidemic going on to have some organized study where high-level evidence would come out, probably, because it is not expensive and non-irritant and it's safe. Thank you, Dwaipayan.
Okay, and next question is, how do you suggest to monitor the disease progress or response to treatment? Diagnostic nasal endoscopy, imaging, or combination of both? Dr. Wendy?
I think it's a combination of both. I think that the MRI with contrast is quite useful if you think someone, the biomarkers in the blood or that are getting worse. Then a repeat MRI will tell you if there's more areas where you've got angioinvasion and you're not getting, the contrast to those areas. But actually on nasal endoscopy as well, you can go and examine with a nasal endoscope, even the pterygopalatine fossa, when you've opened that area up, and if it's not bleeding, then you've still got necrotic tissue there, and if the bone comes away very easily, again, you'll be thinking this is necrotic bone.
Okay, Dr. Raichaudhuri, actually, sometimes it is very difficult to monitor the patient with serial MRI. So here we usually perform postoperatively, and when the antifungal therapies is going on, we are actually follow up these patients with diagnostic nasal endoscopy. So what is your opinion, and when we can send these patients for repeat MRI?
Yeah, considering the constraints in our healthcare system and availability of MRI, then obviously nasal endoscopy, we can monitor how well the operated cavity is healing. Is there good healing? Is there a good vascularity developing? Or is there more progression of the so-called black discoloration of the tissue and the bone that have been exposed at the previous surgery? That would dictate us to do an MRI if there is constraint. But the gold standard would be to do a serial MRI, as Dr. Smith said. So that would dictate us to do MRI. And if there is a clinical sign of deterioration, because if there is a cavernous sinus involvement or something which was not there, which may have led to intraluminal invasion of the internal carotid arteries, so we may have to do an MRI and even angiography. But at least the clinical picture of the patient and nasal endoscopy in an Indian scenario will help us to, judiciously use the MRI, which is scarce at times.
Okay, this is for Professor Martini. Has there been any control study in human subjects using hypochlorous acid in mucor prevention or treatment?
No, well, if there haven't been robust trials. So I think, and this has been part of the problem. It's a very old agent. Like I said, it is FDA approved for cleaning food. It's used a lot, so it's generally regarded as safe. And the problem we've had has been the way it's been made in the past. It's just not stable enough to keep for 3-4 days. And so, as our later colleague just said, obviously trials are needed. However, people have used them in studies, limited studies. And we felt a duty occur to what's happening in India to raise this issue that, there is potentially a very safe disinfectant sanitizer, which could be used on the skin, on mucosal membranes, that could maybe help in a crisis. So what we could do is we can look in more detail on the clinical trials for that specific application. If they were to email me, and we will then do a quick literature search on that and provide that information to you. But to my understanding, there's limited, particularly with this new form. And I think this is the point I'm trying to make. If you want to do trials in India, I would urge you and I would connect you with people who can supply the stabilized form. That's really important, because I think this is what's caused the problem in South Korea. It's caused the problem in Japan. They've used variable sources and the material has broken down. And it's caused confusion, I have to say, in the UK, with our SAGE EMA report on the use of this material for environmental use, because they quoted the paper from the Ebola handling, and the point I was trying to make before, and again that wasn't stabilized. So ultimately, if you got a fresh batch of material and you've got a situation where it's acute, fine. But if you want to try and use this as a versatile everyday system, you need to have a stabilized form. So if you are quite keen to do trials with access to this material, I can connect you to those individuals. I think it's very important that you look into this.
Is there any carcinogenic effect of the hypochlorous acid?
No. Very safe, very, very low toxicity. There is I can provide you so what's happened is it's a PT1 application in the UK, which means it can be used safely on skin. Okay, and that was approved by the Health and Safety Executive in January, and it's now been rolled out across Europe. So that access to that material, I can provide that information to you or to people who are interested. But this is an educational discussion right now, so that's what I'm trying to provide that context.
This Dwaipayan, if I may, this is the point that I was going to say also, that because it is already out for safe use in skin conditions, and cutaneous mucormycosis and cutaneous other lesions are not uncommon in India, leaving aside the pandemic COVID. So that may be a very potential area of study also for mucormycosis, because India, we have a lot of traumas and other things where people do get mucormycosis. And that may be an area of study as well for cutaneous mucor, which will have some robust information.
Yeah.
Please.
This is the situation we're in. We're clearly there's an issue with drug supplies and medication. So you have to look at it from a very humanitarian point of view. Do we sit on this information, not share, or do we share and say, look, there's maybe something we could do now that can help people? And I think that's the situation Wendy and I found ourselves in. Of course, the data is limited, but actually the use of this material has been known for a long time. So it's not new. I think we just forgot about it. I'll be brutally honest. Certainly in the UK, the United States, it's used a lot. Certainly in the cleansing of food. You think about where foods come from. Most of the food is grown in the ground. Think about it, yeah. And so it's washed using hypochlorous to make sure it's safe for consumption.
Another question: has there been any adverse effects of HOCl on nasal mucociliary functions known so far? Actually, as far I know, in lower concentration of 3.5 ppm, there is no harmful effect to the nasal mucociliary clearance. But if the concentration is on higher side, more than 5.5, maybe in that cases, we may face some mucociliary clearance problem.
So my answer to your question, qualification question to the, as far as we're aware, as long as it's stabilized and it's used, like I said, it's a naturally occurring substance. Your body produces it, but we make it artificially. If you don't make it in a way it's stable, then it can convert. So the ones that I know which are stabilized are fine. I can assure you, I've even sprayed myself in my eyes with this material and it doesn't hurt me, okay? And I don't want to demonstrate it because it's not appropriate to demonstrate it here, because I'm talking about educational purposes, but you could spray this material into your eyes. It will not hurt you if it's stable.
Okay, this is for Dr. Wendy. What is your opinion related with the topical methylene blue after endoscopic debridement? And what is your comment related with cumulative dose of amphotericin B?
So, well, I haven't sort of had personal experience of using like the methylene blue or that. So I know people have used that in the past for the activity. Probably makes it quite difficult to know if it's further deterioration in the tissue, isn't it? Because you get that bluish hue from it. So I don't know, I'd leave that to maybe some of the other professors or that to answer that question. With the amphotericin B, you just, you've got your two forms of it. So you've got the cheaper one where you've got to give it multiple times in the day, and then you've got the liposomal one where you can give it much higher doses, but it's more protective of the kidney. So you really do need to monitor kidney function, because remember, a lot of these patients are as well older as well, so their kidney function might not be as good.
Wendy, could you just go to slide 26, please? Is that possible? Just to give people, these are the approvals. So if you take note of those numbers, you'll see it's 26.
Yeah, I'm just going to.
Sure.
There we go. Is that it?
There we go. Yeah, so you can check those numbers out, and they're the approvals for the use on skin in the UK, first one, and the second one it follows on as in Germany. I can give you the numbers for those. That's the top one is the approval in the United Kingdom, and that's now been approved in Germany. I can give you the numbers for those in Germany if you want after the meeting. Okay.
I mean, it can actually be used as well. People use it in normal maxillofacial surgery. It's great against gingivitis, and of course they've had to do the trials to make sure it's all right if they swallow it. There was a study on mice where they actually gave them hypochlorous water to drink rather than normal water, and they didn't have any adverse effects to it. So we know the impact on healing. So even after surgery, I would suggest that it could be useful once you've got the open wounds and the healing process as well. It might get rid of some of the fungi that might be left there.
Okay, so this is for Dr. Wendy and for Dr. Amitabh Raichoduri. Is there any discharge criteria from hospital after clinical and endoscopic improvement? Any guidelines?
Not that I've come across. I mean, I think it's on a clinical decision, isn't it? It's when, you know, and there might be home on posaconazole, which is a tablet. So I know that some areas are using that more. There seems to be a lot of different regimes. So some people keep people on amphotericin for even 8 weeks. Others will give 2 weeks of amphotericin and then go to posaconazole. But it really just depends on patient's response and the extent of disease.
Dr. Raichoduri?
I think I would again second her on this, because if the patient is showing clinical signs of improvement, both nasal endoscopically in the clinical parameters, disease markers, and repeat scan, at least in Indian context, at least one scan before the patient is discharged. And 2 to 3 weeks of amphotericin B is fine, and then you can be discharged. But there is no fixed guidelines template for discharge plan. It also has to be tailor-made depending on the patient. But a minimum of 2 to 3 weeks of M4B has to be given for all these patients.
And this is for Dr. Amitabh Raichoduri. Any correlation of MRI and paraoperative findings for sinonasal mucormycosis?
Obviously, it does correlate. So when you operate, you identify, like Dr. Smith showed us the MRI, that the CT scan shows us the roadmap, that which are the structures involved. MRI actually shows us almost the plane of your surgical plan. And as you start debriding the dead tissue, necrotic tissue, as it starts to bleed, you reach the plane of bleeding and then correlate with the MRI finding where it was not enhancing. And then if it correlates, then probably you are 100% sure. But one thing is 100% sure, that you, irrespective of what you have, many studies have proven that you have to go to the pterygopalatine fossa, which already has been highlighted.
And another important thing is that the hyperintense area where there is vascularized tissue is present, then if there is enhancement, then also we can actually leave behind those areas, because at those areas antifungal therapy can reach, but the devitalized area should be removed, as you have mentioned, up to the level of the normal bleeding mucosa, and rest can be left alone so that the antifungal therapy he can take the care of those areas which are well vitalized.
All non-enhancing tissues have to be removed.
Have to be removed.
In a T1 sequence.
Yes. So, Dr. Wendy, any comment regarding the cumulative dose of amphotericin B? Do you suggest it?
I'm not sure that's to hand. I mean, there's guidelines per weight as well. So obviously someone who's younger, I think I had it on one of the slides. It was at 0.5 to 1 milligram of the standard one and 5 to 10 milligram for the liposomal per day. But again, you have to modify that according to renal function, and that should be available on drug formularies.
And in case of intracranial extension, do you suggest a neurosurgical intervention or debridement of the rhino-orbital portion and then medical treatment continue?
I would confer with the neurosurgeons in the UK anyway, if the practice was there, use their expertise really.
Okay, and if the PL-PR is present but disease focus present in the orbital apex, eye removal is required or not? This is for Dr. Wendy Smith and also for Dr. Amitava Rai-Chaudhury.
Well, if it's devitalized, and that you have to remove all that area and then you tie off the apex bit.
Dr. Rai-Chaudhury?
I think here I would personally discuss with the patient and the family, because this is a situation where life saving is more important than organ saving. At the same time, if the patient still has perception of light and all these things. So I would also explore the possibility of debridement intraorbital through any other route, endoscopic route and a combined route, and try to save the eye, depending on the consent of the family and the patient, if the patient is able to consent, because that's a very gray area where there is no guidelines which play. Individual patient, consenting, surgeon's threshold of doing things, and availability of endoscopic versus oculoplastic service will dictate all these things.
And in these cases also, I think MRI with contrast will be very much helpful.
Obviously, that is must.
So we are having lots of questions, but it's almost 9:30 here. So with this, I want to thank and congratulate Dr. Wendy Smith, Professor Luigi Martini, and Professor Dr. Amitava Rai-Chaudhury to be present here and share their views with all our members. Right now, I am handing over this session to Dr. Snehasis Barman, our Honorary Secretary of AY West Bengal, and Dr. Subhajit Banerjee, our President of AY West Bengal.
So, Snehasis, shall I? Hello?
Yes.
So,
yes,
so this is, now this is my proud privilege to offer thanks to you all. At first, I thank Dr. Wendy Smith and Dr. Luigi Martini for spending their valuable time with us and delivering an excellent academic discussion. I also thank Professor Dr. Amitava Rai-Chaudhury for his part of this discussion. I thank all our senior and respected colleagues, our teachers, and our junior friends for being with us during their webinar and for their valuable support throughout the year. I thank the audience for listening this program and request them to please subscribe in our YouTube channel to enable them to watch all our academic programs in future. Lastly, I thank our beloved Secretary, Dr. Snehasis Barman, and our Treasurer and Trustee Board member, Professor Dr. Dwaipayan Mukherjee, for making this excellent academic program happen. Thanking you. Over to Snehasis, please.
Yeah, thank you, Dr. Subhajit Banerjee, our president. And besides thanking our speakers and moderator, I want to thank Dr. Amitava Rai-Chaudhury, who has joined us and shared his suggestions and knowledge. I thank all the all the audiences who have joined us in our YouTube channel and stayed with us throughout the program from all over India and also abroad. Thank you all. And so thank you. There are more questions are coming still now, but due to lack of time, we have to end the program. So we hope to organize another webinar in future and hope to get Dr. Wendy Smith and Professor Luigi Martini with us in future program also. Thank you.
Thank you very much.
Thank you.
Thank you. Good night.
Good night. Good evening. Good night.
God
bless you all.
Good night. Good night to you all.
Okay.
Okay. Thank you.
Bye.